A new type of information has emerged. When we start, we learn with headings and concepts. Our sage and learned teachers bring their wealth of clinical experience to guide us as we start to construct our own clinical approaches to difficult and varied presentations and episodes of care. As we proceed in our clinical work, we start to accumulate our own experiential stories of what we did in this particular situation and how it worked out. But now we have forums where patients or their families swap stories about how they survived, what helped and what didn't, and more importantly, what they did when things got stuck or the standard approach just didn't work. A good example of this is a forum for parents of young people with eating disorders who are being treated with the Maudsley approach. Now, I would be able to explain what this treatment was about in general headings, but the fine-grained questions I would have to get from a specialty unit or after years of experience. By reading the stories of parents and the advice they have for each other, I have a new rich source of fine-grained information that, added to what I already know, i.e. linked in with a rich context, makes it all the more valuable. Medicine is a discipline that requires lifelong learning. As medical students, we start pretty content-free, and during the course of medical school we'll have probably 3 passes at the same body of knowledge. We start at the trunk and learn the basic branches. We revisit it in our first clinical context and move to smaller branches. Towards the end, we have to consider treatment and consider the tweaks. Each pass extracts something different. When learning psychiatry, we go through a similar process, moving to the basic tenets and basic training, fleshing out the headings ready to regurgitate for exams. By advanced training, our requirements are more sophisticated, abstract and specialised, with an emphasis on fine-grained treatment. A textbook runs out, even the expanded version at basic training. Our need is for well-parcelled information that is targeted to the way we learn and what work our learning is required to scaffold. This is a new site that has come out of a university department in Ireland. The Video Journal of Psychiatry is sponsored by a drug company foundation and gives lectures as a talking head PowerPoint with downloadable MP3 files and printable notes. This is a very attractive package to many trainees and suits the way some people learn. I see it as a good example of doing an old thing in a new way. Technology aside, it's still giving a lecture. When surfing the web for information, there's no shortage of good quality material on most psychiatric topics, but chasing links and bookmarking pages becomes messy. They still have to be read. Everybody has their favourite page or source of information on the web, but no one I know has any time. We are now all required to demonstrate lifelong continuing medical education as a condition of our registration. The idea of a liberal education where we learn poetry, philosophy, the natural sciences, literature and tapestry at the outset, and then specialise to the career we hold for life, is over. When I did actually have the time to engage in this, when I entered tertiary education, I was too distracted growing up, and it was pitched more at the reflective bent of a 40-something, the age of many academics. With the multiple roles I fulfil professionally and personally, my attention span can't fathom this kind of learning. It more resembles that of a teenager. Now, any record label knows what that is, the length of a pop song, 3 minutes, 40 seconds. The net surfing mentality, clicking and scanning pages, fits better with this, where information packaged like pop songs, conceptually organised with verse and chorus, catchy rhythms and melody, are easy for our information overloaded brain. This site is a good example of the 3-minute 40-second idea. Information is pre-packaged for where it is needed and how it is needed. This private institution prepares US psychiatry trainees to pass their board exams, a highly geared and specific specialty exam. History taking is timed down to the second, with when to ask what, decision paths plotted to fit into the tight time frames. The information is accompanied with some tips and pointers on what works and where candidates fall down. A textbook is largely expounding declarative knowledge. This is the stuff you need to know. As they're written in bulk and have to introduce a topic broadly, they're frequently inclusive and general in their scope. Many psychiatric textbooks often include clinical vignettes to humanise what they're describing, and this can be an effective tool. But when we sit with people as clinicians, we don't march out our knowledge in those similar chunks. It's more, when do I do what and why? So when do I march out the latest clinical practice guidelines on a particular disorder? And when do I sit with my head on one side, nodding, saying, sounds like you're really having a rough time at the moment? It's the procedural knowledge, the sense of what happens next. Increasingly, patients can go to the internet for good quality information. But in our role as doctors, we do so much more than manage diagnostic facts. Frequently, this is referred to as the art and science of medicine. As our knowledge increases around what it is that works with therapy, there's a discussion talking about the relationship and the person of the therapist being as instrumental as the fact of their theory. Here we see an example from anzapp.org of a trainee writing an article on one of the most difficult parts of the clinical exam, the observed clinical interview. Not only does this article impart knowledge, an exhaustive and detailed list of important diagnostic algorithms, but offers the reader encouragement to persist and not let the initial difficulty and low confidence overwhelm. Medicine has many accounts of puritanical and demoralising teaching, where a medical student or junior doctor has frequently heard the "in my day" story, where the listener's application and effort are viewed as inadequate. The underlying message seems to be that when they finally reach similar seniority, they too will have to condescend and demoralise to mark their status and define their stage in a medical career. But in this instance, the trainee has had the opportunity to contribute to their colleagues and profession in a way that is less formal and more conversational. The reader gets the experience of being cared for and shows their appreciation. "Bloody marvellous," states some comment. "Wish I saw this before the October clinicals. Thanks for sharing." If we imagine the textbook as the lecture, then maybe this kind of article more resembles the tutorial, where there's a more human and targeted exchange, where the process of gaining knowledge is discussed alongside the content. And what about the international language of sound and movement alongside English? What if we could show a panic attack instead of describing it? The trainee could get to experience a new quality of understanding. As one human being viewing another and hearing another, the capacity to understand this condition takes on a whole new dimension. To know of the suffering in a human way will surely inform the treatment response. In this YouTube video, a courageous young man videos himself while in the throes of a panic attack. Complete with sobbing, whimpering, and a body recoiling in the corner in the fetal position, the viewer is able to understand suffering. There's a second video where Kevin is able to tell of his journey to recovery and the kind of things that were most useful in helping him at the height of the panic attack. The viewer is able to see someone who is well, competent, articulate, and optimistic about their future, a persuasive reminder to clinicians of the possibility and true worth of recovery. So I'll finish with an online textbook. This is an HTML version of a free online general psychiatry textbook written by Professor Saxby Pridmore from the University of Tasmania. At the end of one of the chapters on anxiety and possible treatments, a comment is made questioning some of the assertions made by the author. Really, he engaged the author in an academic debate that could only previously be seen in letters to the editor in a peer-reviewed journal or at question time at Congress. The author then has an opportunity to respond. Indeed, the textbook gets to answer back.